In part 3 of the 12-lead ECG review, we're going to discuss briefly the precordial leads, V1 through V6. We're also going to discuss localizing the MI and the relation of the coronary arteries with the MI as you would see it on the 12-lead. So our objectives: identify the precordial leads and the areas viewed by each, describe the location of the heart experiencing the MI based on coronary artery occlusion, and identify the standard layout of a 12-lead ECG printout. So your precordial leads, these are also called your unipolar leads. So these are added to your 6 limb leads, your limb leads being leads 1, 2, 3, AVR, AVL, and AVF. 1, 2, 3 being bipolar leads, AVR, AVL, AVF being augmented leads. These are added to make your additional 6 leads to make the 12-lead. So these precordial leads view on the horizontal plane, meaning that they view from the inside out, and they are placed on the chest so that they can view the left ventricle. So they will view the septal wall of the left ventricle, the anterior wall of the left ventricle, and the lateral wall of the left ventricle. So your limb leads, which are leads 1, 2, 3, AVR, AVL, and AVF, combine together to make the hexaxial reference system. This is important to use when you're determining axis. We're not discussing this right now, but your limb leads and your precordial leads together make your 12-lead. So your layout on your standard 12-lead ECG. So you're always going to have your limb leads, leads 1, 2, and 3 in your first column. Your second column would be your augmented leads, AVR, AVL, and AVF. Your third column is going to be V1, V2, V3. And your fourth column is going to be V4, V5, and V6. So in order to localize the MI, you need to understand how the layout occurs, and you need to understand the concept of contiguous leads. So contiguous leads are going to be leads that look at the same general area of the heart. So for instance, leads 1 and AVL, you can see they're the same color. They look at the high lateral wall of the left ventricle. They are usually supplied by the left circumflex artery. Leads 2, 3, and AVF, they're contiguous, and they view the bottom portion of the left ventricle, or the inferior wall. These are usually supplied by the RCA, although there are times that the circumflex can run posterior and down into the inferior wall and supply in the left coronary dominant patients that we had talked about earlier. V1 and V2, so they take a look at the interventricular septum. V1 is going to be the lead that's best used to identify and diagnose bundle branch blocks. V3, V4, they're anterior, the anterior wall of the left ventricle, usually supplied by the LAD as well. V1 and V2 is supplied by the LAD. And then V5 and V6, usually, which are low lateral wall of the left ventricle, they're usually supplied by an extension of the left circumflex as well. So on this view right here, you can see leads 1, and AVL. So that's going to be your high lateral wall. 2, 3, and AVF. That's going to be your inferior leads. V1 and V2. That's going to be your septal wall leads. V3 and V4. That's going to be your anterior, and then V5 and V6, that's your low lateral. It's important to note that V1, V2, V3, V4 very rarely have a isolated MI. Usually you've got anterior wall involvement with septal wall involvement. So using the precordial leads as a camera, you can think of leads 2, 3 in AVF. The camera is on the left leg, so the positive leads on the left leg, and they view the inferior wall of the left ventricle. 1 in AVL, this is going to be your high lateral, so they're going to view the upper portion of the left side of the heart. So the camera or the positive lead is on the left arm. Your low lateral, V5 and V6. So your positive with these are going to be V5 and V6 that you put on the chest. So remember, your V leads, V1 through V6, are unipolar and they record on the horizontal plane, whereas leads 1, 2, 3, AVR, AVL, and AVF, they record on the vertical plane. So they don't use the same positive leads, even though they're recording in the same general area. So V5 and V6 is low lateral. So you could say that lead 1, AVL, V5, and V6 are contiguous leads. The septal wall, so this would be lead 1 and lead 2 right there, and they're viewing the interventricular septum, which again is a great place to see the bundle branches, because the interventricular septum is where the bundle branches start. V3 and V4. So this is going to be on the anterior or the front wall of the left ventricle. The positive electrode for these two leads is placed on the anterior wall of the left chest. This is why they're called anterior leads. So another concept to think about, what about a right ventricular MI? So we said that the inferior leads are supplied by the RCA a large portion of the time. So it would only lead you to believe that a large amount of inferior MIs have right ventricular involvement, and that is true. So what do we do if we see an inferior MI? We take V4 off, move it to the anatomic same location on the right side, and we run another EKG, making sure that we mark it V4R. And then we determine, are we having some signs and symptoms of right ventricular MI, which would be your signs and symptoms of right ventricular failure. LAD occlusion, so your left anterior descending, and it also depends on where it's at, but if it's up high, it can affect a large portion of the anterior septal and possibly even lateral wall. And of course, the circumflex occlusion could affect the lateral leads, and if it is supplying the inferior portion of the heart, it could affect the inferior leads as well. So this is localizing the MI, and this is also the end of part 3.